We have the first case coming up right up, and I also want to make sure that you all stay till the end, because at around 5 minutes of 6, we're going to have a raffle for the usual raffle that Dr. Sharma always puts up for the iPad mini and the iPad Pro. So make sure you all stay. We have both of these right up here for raffles. And please feel free to put in your questions using the app. And we go straight live to Dr. Kinney as our group takes their seat. Dr. Kinney, I see you live. Good morning.
Good morning,
First case.
everybody. Do you have the case number 1 showing up in the side?
Absolutely, absolutely. Let's go.
Okay, I want to welcome everybody and start the first case, and just want to introduce everybody. You have myself, Dr. Sharma, and I have Joe Sweeney as our operators. Then we have the interventional fellow. We have the largest intervention fellowship program, about 12 interventional fellows, and they are here also to show you, and the entire cath lab staff is in the back. So case number 1, you have AA, who is a 52-year-old male, who actually presented with chest discomfort. He had a cath at an outside hospital, actually in another state, though he has been a Mount Sinai patient for many years. He is known to have ischemic cardiomyopathy and multiple PCIs here as well as at the outside state. And the recent cath had shown that he had a EF about 20, 3-vessel disease including left main disease, and there he was referred for bypass, and he said, no, I do not want bypass, came to Mount Sinai as the evaluation for transplant. So transplant team saw him since he was 52. They still presented to us saying that is there something we can do rather than him going for transplant straight away, mainly because all 3 territories were viable when he had an MPI. He already has an AICD. Risk factors include diabetes, hypertension, hyperlipidemia, good medical therapy, as you see there. And if you go to the angiogram, if you see, this is his EF.
Wow.
And right coronary artery actually had disease which had been taken care, and this is the left main that we have, which is essentially distal left main, maybe I would say 30-50, but you would see LAD. The previous stent of the LAD, which is mid to distal, has restenosis. There is a restenosis of the diagonal, which was a large size diagonal. The stent has restenose. But now you see ostial circ being involved with a large size OM1 and the entire circ. This is where we are.
So the morning theme is the left main, and we had 3 left main cases of varying lesion morphology and patient characteristics. So we start with this case with the poor ejection fraction, and rightly so. We can see Dr. Keeney has already done the Impala.
So tell us, we have this amazing panel, and obviously this is a very high risk case.
Yeah. You can show the IVUS by the side.
Show us what you're planning and what you are, and we'll get the panel speaking. We can show the IVUS
So we just did the IVUS. If you can see, this was just the distal left main to ostial LAD. You can see the IVUS frame there. Can you show it up?
Not yet.
Yeah, stand by.
It would be also helpful if we see one more view of this, Dr. Kinney.
Of LAD another view or no? Yeah, right here.
Except now we just have the IVUS.
Yeah.
Show us the angio. Yeah.
Yep. Good. Okay.
Okay.
Good. Okay.
So what we plan to do, if you see that, though I know it is stent, but there's still a lot of calcium at the distal left main, also seen by the IVUS. So what we are going to do is we'll do rotational atherectomy into the distal left main to LAD. We have picked 175 bar, and then what we will do is wire the circ, and we plan to do 2 stent strategies which will involve both LAD as well as circumflex, and we will go over what's the various bifurcation stenting strategy involving left main as we come at the time.
And the ramus also, it's truly a trifurcation. The ramus also we need to address separately.
That's where I was focusing on, because I see it really looks like there's a very, very large ramus or first diagonal there that looks also to be involved. We have this amazing panel here. I see John LaSala here sort of looking up, wanting to already make a point about perhaps hemodynamic support, and technique, what have you, and the idea of hemodynamic support
Involved.
comes here
You're
first.
primarily involved.
Obviously, it's an elective patient. Is that something that you would consider, or?
This is obviously a very common scenario now, particularly in transplant LVAD centers. You get a number of people who have ischemic cardiomyopathies. If you need a transplant, if you need an LVAD, that's great, but unfortunately they carry with them a whole different set of problems. If you can recover the coronaries to the point of improving the ejection fraction, it's a much better alternative, particularly in a 52-year-old. What strikes me as interesting here is a couple of things. Not only the anatomy, but the fact that you've got a very bad ejection fraction for somebody who does not look like they've had a lot of infarct. There's clearly triple vessel disease here, but we don't see something that's really where there's been a discrete infarct. So you wonder if he's got a mixed picture, both ischemic and a non-ischemic cardiomyopathy. Secondly, about the actual type of anatomy, clearly hemodynamic support is a classic indication when you start to get down in the well below the 20% range and you're looking at triple vessel disease in conjunction with atherectomy, then it's almost virtually mandatory unless there's a contraindication for an Impella to put some in and provide some hemodynamic support. But you have the combination here of trifurcation where you end up almost with two bifurcations for the price of one. The LED is coming out of the left main, the ramus, but ramus seems to come out of the proximal port of the circumflex. So you may end up doing something like a T stent for that component, ramus circumflex, and then like a V stent for the LED and the rest. So I'd be curious to see how the team approaches this.
Yeah, I think we're going to see what the bifurcation approach is going to be. It's going to be very, very interesting. But also, you saw that rotational atherectomy came up first. Now, anybody else on the panel have any kind of input on that? Ron Waxman?
No, I would support the rotational atherectomy in the Impella. My question, do you feel a value in measuring, monitoring PA pressures and wedge pressures during the procedure? Because in the old days, when we didn't have all this stuff, this was a very good indicator where we're standing and how we keep the hemodynamics. So I don't see here any SWAN, but I was wondering, Samin, what is your thoughts about adding a SWAN to a simple monitoring of the PA pressure?
Then you should have put a SWAN.
No way.
Dr. Kinney, did you hear that question?
Excellent question raised by Ron Waxman. And EDP on this guy, actually, if it is 25, that's why I think Impella is a perfect hemodynamic support in this patient. But the question is the same once we were part of all the Impella trials where we had to do right heart, cath with the PA pressures every half hour, before, after, in between, and all the thing. I don't think there was any clinical decision making when we use a right heart during the case.
You need one more wire to the ramus.
I'm going to take out. No ramus?
So,
Anu, I had two questions for you also. One I think has gotten answered already. Would you have considered a larger burr for the LED?
No,
And
that's
the
what
second,
we just discussed, that when we went over this case, that we thought 175 burr, and once we saw the IVUS, you saw that was tight, that was actually in the ostium as was further. We said, okay, let's stick to 175, but then if you see, the burr actually, just with one pass, we were able to do that we probably should have gone with the straight 2 burr.
Yeah.
Yeah,
Now talk about also, in terms of the ramus, you want to keep that vessel totally innocent or wire it, do something or no? So I think this is
You can ask a question to the panel, but I will say I would want to leave it alone.
what we're seeing, first of all, is that there are 3 wires, and so we're seeing that you're protecting pretty much everything.
One was the rotawire, which you took it out.
But I see them. One is a rotawire, one down the circ, one in the LAD now.
Ready?
So we are using a flex tome to the
Yeah, it looks like you're...
Good, go up. That's a...
3 or 3.5?
This is a 3 to 5.
Okay.
So this is a down.
Need to move a little bit.
Same thing, if you are using for the native vessel flex tome, any kind of atherotomy balloon, try to use a quarter size smaller, half size smaller. So our plan would be that we'll put a 3-5 stent in the circ.
And ask the panel that if
Marie-Claude-
anybody will put a wire into the ramus.
Yeah,
I
so
mean,
that
will
was
protect
my
the ramus. I
question.
think that's the
Marie-Claude,
important question in day-to-day life.
We have Marie-Claude Maurice here, who's going to actually give us the left main bifurcation talk in a very short while. What do you think about the technique so far? What do you think about the wiring of the ramus and the strategy here?
Take a picture.
It's a very interesting and complex, and we must congratulate the team to do it live, because it will be very educative. But yes, when there is large branches like that, so the safe size is to protect all of them for us.
Okay.
What's the balloon you have now?
So what's your plan, Dr. Kinney? Tell us
So
how
now
you
we
decided
did the
how to treat
flextome.
this.
We saw the flextome of the circ looks good.
Very good.
The so-called ramus so far looks good. I personally would not wire that ramus, but
I
all
definitely
depends.
will wire the ramus.
Okay.
It costs you just a wire.
Go.
Yeah. Yeah.
And the ramus looks large. And there's some disease in that ostium of that ramus.
Yeah. I think the argument of the wiring is, remember one editorial by Colombo, because one of the studies showed 18% side branch closure and they didn't use the wire. What I also believe that even if you don't intervene, just having a wire change the angle favorably, which has been shown by some publications, and that clearly
use
that
a
it make
flextome
it
there.
favorable in terms of stenting and less, even if you don't have to intervene.
So, Dr.
That
Kinney, I still see that your burring maybe not have been
Yeah,
enough,
yeah.
right?
So I think very interesting. So what we are going to do is use the same flextome and go back there and open that area. We'll use a flextome 3.25 right now.
You know,
So
it
that-
happens with the angiogram which they showed earlier was from a patient who was, when presented originally outside, vessels looked small. But today, when we saw it today, when the decision of 1.75, we already, because you discussed these cases beforehand, the clearly was, it could have taken even 2.15 bar using the 8 French guide. Because for 2.15, you need an 8 French guide.
Is the blood pressure okay? Does
Yeah, so far we
Impella
are
support
running at
you
100.
during those
Please
interventions?
Yep, with that Impella.
Show the hemodynamic, please, if you can.
That gives you peace of mind when you use the Impella. You don't have to worry so much.
Any specific disadvantage of putting a wire in ramus, or it's just
No,
making the things
most
complex?
important is having 3 wires at a given time, risk of thrombosis, thrombus formation go.
4.
That's the only disadvantage.
What size is this flextome?
325, the one we use in the
325.
circ.
Yeah, now it opened up a little bit.
Little
A
bit
little, but
waste.
still
Yeah,
see
still
a
there is
little
a waste.
waste there.
Yeah, at the place where there was most calcification.
Now it
Then we
opened
opened
up.
up, no? You want to go with the angioscope?
No, it opened up now.
I know it's very rare complications, but I've seen it at least once when you're using the flextome
Go up here.
and you have multiple wires. You can cut one of the wires on the side branch, or at least shave some of the polymer coating on the wire. So I think, again, that's something that
The Ran, would you put a wire? But what is your opinion?
my opinion was like you. I mean, I don't think that the Ramos right now does not need a wire at this point. I'm
No.
afraid that if you put too many wires and you manipulate, you can
What did you say?
cause some damage to the polymer or some.
So Ron is in agreement with you, Anu.
Good.
Yeah, no.
He agrees with you. Dr. Sharma wants a wire.
Yeah.
I would have put a wire.
Go.
I don't know how many people on the panel here would
Dr.
put a
Bahal
wire.
wants to put a wire.
Marie-Claude would put a wire. Carlo DeMario would put a wire. All these people want to put a wire with Dr. Sharma. Let's see. Let's see what happens.
Down.
So, what is your strategy? 2 stent, 1 stent. How
Let's
are you
see the final
deciding?
picture. Good, no?
Yeah.
Are
Very
you
good.
gonna?
Take a picture.
Are you gonna
No,
show us?
this will now. 1 second. This angiogram will decide. I think
Nice.
we have done good atherectomy, atherectomy, and we are ready for a stenting strategy.
And the
Initial-
Ramos looks compromised somewhat now.
I think our plan was to have two stents. Same, we will do a stent into the circ and stent into the left main to LAD using a mini crush technique. But what I want to show at this time is the app that we have developed here in Mount Sinai, using all the various bifurcation techniques. It was started last year, but 2 fellows especially helped me to develop this app. If you can quickly show the app and show the fellow there.
Showing there.
This is Samit Bateja, who not only has a cardiology and interventional will be becoming an interventional cardiology fellow next year, but more important, he has a lot of interest and training in IT also. So that is why I think we were able to develop the app. Samit, start going through the...
I know these younger generation are very
Yeah.
smart on the computers.
They're all... yeah.
Okay.
So there we are. This is how you're going to
Because
see.
they're texting all the time.
So you will see bifurcate. It is essentially saying aiding how to take care of a bifurcation lesion. Keep going next.
Okay, take us through the app.
So Mount Sinai App Lab will be helping us to get it go live with the Apple Store. So that's how it's going to be. So you have B, again standing for bifurcation. If you see the logo also looks nice with the coronary artery and it's a LED diagonal. So bifurcate, go next. So this is a disclaimer, essentially saying it is a tool to tell you don't later on blame the people who made the app since the patient crashed on
That's
you.
a good disclaimer,
Yeah.
right up front.
Yeah.
Okay, and
by a lawyer.
essentially you'll have two. Are you dealing with left main or you're not dealing with left main? And then you have a home button. Go to the home button. And when you press the home button, what you will see is this is called the glossary, where go to the first one, the description of entire bifurcation, the various techniques of the balloon selection, wire selection, how will you deal with the complications will be there in the glossary. Also there will be a hyperlink when you're doing the case that you're going through the steps and suddenly there is a problem, there's a hyperlink connected to the glossary, so you'll know this is how you have to do it. So now go to the next, this is the example of the glossaries here. How did we classify? And now go back to left main. What is that bifurcation next? Who is that? Yeah, press that. This is the app team.
That's a good team.
So okay, left main shows the left main now. So this is the Medina classification. So we would consider here 111 because distal left main did have a 50% lesion. Most important, we say that is hemodynamically stable or unstable. Because many times we are facing patients who are hemodynamically unstable or patients coming, acute MI, we do see couple of times left main disease. If it's hemodynamically unstable patient, we have a different strategy where you can use either SKS or V-stenting that you will do the case in a couple of minutes and come out. In hemodynamically stable patient like this, the various technique that you can opt. Here, like I said, I thought we will go with mini crush, show the mini crush. So there's a description of mini crush versus DK crush. So if you see here, this is where we are, wire both the vessels. Keep going next. Main vessel side branch, next. Then we have taken care of the main vessel as well as the side branch. Keep going fast here. This is ballooning the side branch first. If you are not happy with the initial balloon, consider atherectomy, next. And this is where the stenting exact steps, very essential for especially for the younger generation who are learning to do these complex cases. So what you'll do is in a mini crush you will place your side branch stent, which is a circumflex with 0.5 to 1 millimeter sticking out into the main vessel, and then you have the main vessel stent which is between the LAD to circ. And here again with the description we have considered left main to LAD as the main and circumflex as the side branch, and that is where we are. We are going up with the...
Okay. Well, would anybody consider a single stent here on this panel? I know that our French group
is this?
like to minimize the amount of
other one?
stenting, but with these two large vessels, would anyone just try to go? Dr. Usia, how would you approach this? Is this exactly how you would go with a two-stent technique here in this case?
I agree with the operators, and I would use the mini crush technique.
Mini crush.
Yeah, definitely,
Anyone would go with a single strategy. Marie-Claude?
Would go to provisional as usual and see
You
the
usually
second
go
stent
provisional and
only
then-
if needed, if FFR positive on the second vessel after kissing.
Okay. All right. So
Okay, so I
take
have
us through this one by one, how you
So-
chose the sizing, all of that.
So if you see the circ size, it was a 3.5, so we took a 3.5/16 to the circ, and then we are going to go with the 3.5/28 to the LAD. So this is where we are, we already placed. And again in the app, in the glossary, we will always mention, go to the most difficult part. Usually is the side branch is the difficult vessel to place the stent. since there is the angle, whether it's a diagonal, RPDA, or we're talking about circumflex. So this is where we are now. This is exactly, you see that, how we are shown the picture there?
The
Now-
length of the stent is a lot longer in the LAD. You're trying to cover both the LAD and, of course,
Up to the mid.
the left
Yeah, yeah.
main.
Yes,
You're
yes.
going to come into
Sir,
the
you have it?
ostium or just before the
Yes,
ostium? I
now
don't
you
think you're
see,
going to...
you see the picture there in the app. So now I'm pulling back the circ a millimeter into the left main, and which time the LED always, the left main to LED always moves. So I'm pulling back and adjusting that. Okay, who was ready? Sine?
This is the circ.
Okay, inject.
Looks like you need to come back a little bit with
Let
that
me see. I
circ.
think, yeah,
Stent.
it went down. No, it looks okay now.
Oh, good, good.
Everybody agree? Or you want
Yeah,
me to pull
I-
back the circ a little bit?
I don't know that this is going to... It looks like you might spare, like, it may not even come into the ostium of the left main. Yeah, maybe there.
Some die, some die. Now
Yeah,
we are good.
that's
Okay?
good.
Okay, go up with the circ now. That's show the app.
Circ stent.
Keep going.
Yeah, we see the app, yeah.
So the circ stent is going up. Good. So you make sure your full deployment 12 to 14.
14 ends.
14, good. Cine that down. Go up again second time. This is one which we do. We always go twice because first time we know we just deployed the stent. Second time it's nicely done. Looking good. Everything expanded well. Right?
Yeah, looks good.
Down. So the next step is you're going to take the SDS of the circ out, which time the stent may move, which you see that it is moving,
Yeah.
don't worry. I'm taking it out. So the next step, see, as the app says, we are going to make sure your the circ looks okay. Looks good.
And even
And-
the side branch is still open.
Nicely open. So now I will take the wire out. Is the app saying that?
Yep.
Good. Wire is coming out. We are confirming again that the LED is good. Some die. Good. I'm going in a little bit. Okay, good. Good. Go up. Dilate.
And now you'll go up with your... There you go. We'd
Nice.
like to see that you get a good dilation on
14
both.
hemispheres.
Down. Go up again. So now what I have, if you see, I have the fielder wire which was in the side branch in the guide. So I will take out the balloon of the LED into the guide, then we rewire.
And wire the circ.
Yeah. Now this is where again an important step which is coming out more and more, that the proximal optimization technique, what should be considered in every bifurcation, that even before you think of the kissing balloon. The main reason being, if you see the left main almost 5.0 and we have put a 3.5 stent.
Yeah.
So I may have difficulty in wiring the side branch. Let's see. In that case, we may have to consider a pot first. Essentially, what pot will do is optimize the proximal part of the stent so
To
that it will
allow
be
you to
easier
get
for
into the circ,
the subsequent wires and balloons to get when you're into the side branch. So that's another thing that we have mentioned there, though we have not made it a mandatory that every case you have to do a pot. Try to wire it first. If it does not go, then you consider pot of the side branch.
So let's see how you wire that circ.
Yeah, I'm just taking out the two balloons out.
Yeah, and the advantage of the pot also
Clean here.
is to
Yes.
avoid, as you were saying, it's a 3.5 stent in a 5.0 in a
Exactly.
5.0
Good.
left main,
Go.
so the
Good.
wire can go outside. So the advantage of the pot
Ready?
Exactly.
is that you
so
oppose your stent.
very important not to be behind, right? You want to be through the stent.
Looks nice.
Really, really good. But we
So we'll
obviously still
try
need
to
kiss.
wire. And once we wire, it's very important, especially when we are doing left main, that for your side branch, your side branch balloon has to be an NC balloon. Now we are going with if you are talking about a single stent strategy, part of the Excel was the same. It was left to the discretion of the operator, that if you do a single stent across the main vessel, which whatever you do, the side branch, the final kiss was left at the discretion of the operator, was not mandated.
Except I think you need to finally kiss here
Right.
for sure,
That's what they asked for. We have a
right?
3-5.
Everyone agrees
Open it
here,
up.
we cannot leave without a final kiss.
And then where is the LED? LED, what do we have?
3-5.
Anu, if,
3, 5, what, 20?
Anu, I have a question. If you had this a true trifurcation, because this intermediate is arising from circumflex, you have chosen a different technique or tap or with the
Sorry?
same. Suppose this ramus was arising from the true trifurcation. It's arising in this case from circumflex. There is a margin. So you have chosen another technique for doing a bifurcation or same crush?
Very interesting point that you have raised. If the ramus had disease, okay, and the main circ did not have disease, we would have probably stented from the left main to ramus. One way. If you had disease both in ramus and circ, you could take care of the ramus ostium first, whatever you want to do, and then just stent into. Okay, now you see this is a NC balloon which actually went in.
Yeah,
This happens especially when you're dealing with large vessels in left main. When you're dealing with the bifurcations of a smaller vessel, which is LED diagonal, RCA, RPDA, NC balloon will not cross the side branch directly. You may have to go with the compliant balloon first, dilate it, and then you go with the NC balloon. So we have a 3-5, 3-5, 15 into the circ, and we are going with a 3-5, 20 into the LED. Both are NC balloon.
okay. So you'll kiss, and then the big question is imaging finally. Is it IVUS or OCT? What are you using to optimize your, and obviously, are you using imaging? Of course you are. You're a big imaging guy.
No, in this case, it has to be IVUS.
Since it is left main, it has to be IVUS. You'll never be
Okay.
able to see a lot in OCT. Two reasons. One, it's a proximal vessel with the same distal left main, you'll not be able to see. 3, in the large vessel, no matter what, when it's more than 4O, you will not see a good, you'll not be able to see the vessel well with OCT. Now we are going kissing. So same, go with the circ first. Circ. What do you do? Open.
What's
See,
amazing is how comfortable everything is with
18,
Impella
18,
on
18.
board. Does everybody notice
Go, 18.
that there's really hemodynamic stability and ability to do a great job
Go up,
in the
okay,
left
good.
main
Now where are we?
is tremendous with the use of the protection device.
up, yeah.
Impella,
This would be a
yeah.
good time to take a look at the hemodynamic
Already
screen
go.
while you've got your balloons up in the
18.
left main,
Yeah.
just to sort of show you what happens to the pulse pressure.
You're good.
Yeah, you
You're
want to
good.
show us some of the
Down.
hemodynamics while you're doing these kissings?
Good. And now go up.
Dr. Kinney?
You can show.
Yeah.
Now kiss. Now kiss.
And when during the kiss,
Down.
we'll see what's going on with the hemodynamics.
Down.
And what happens
It's
to
Now,
the
going
ramus?
down. It's going
If you see that since we had 3-5, 3-5, the circ balloon moved down.
Yeah.
Yeah, that's one thing that you see because it's not able to accommodate, the proximal vessel is not able to accommodate because we were going what we did was, circ we went 18 atmosphere, really made sure the ostium opened well. LED we went 18, 20 atmosphere, we made sure everything went well. But when we are doing kiss, we may have to go lower, 12 to 14.
Ready?
You go 14 to the circ, 12 to the LED. So
Right,
this is
so
it.
now you're
Yeah.
really showing us both
Nice kiss.
12, 14
These are-
kissing, and you see,
Down.
you see the
Down.
hemodynamics.
And a very important point here, which will also make sure the app will know that your proximal dot of the balloon is within the stent, even though your tapering part of the two balloons are in the unstented area, which is okay, but you have to make sure the dot is at the proximal edge of the stent. Yeah. Yeah.
Okay.
We are doing good here, and I think Dr. Sharma's guys are calling
Okay.
you to the other side.
We'll come
We'll
back,
just
we
take a
want to
picture.
see your final images,
Yeah,
of course.
ready?
Anu,
Show
one
us.
quick last question. Where would you remove the impella, in the cath lab or a few
Yeah,
hours
right
later?
now we'll be in the cath lab.
Very
So
nice.
if you see there, the ramus is still looking good.
No, it looks really, really good. No wiring. I guess you were right. Good.
We will
Okay.
do the IVUS and make sure the left main is well opposed before we come out.
Okay, sounds great. We go to Dr. Sharma, Dr. Kinney?
Yes.
All right,
thank
we
you.
are
All right.
already here.
Case number 2, Dr. Sharma.
Yes.
Please, you're up.
Okay. So you see here, again, as I said, the left main theme. This patient presented with dyspnea. Outside cath showed left main and 3 vessel disease. Patient has various risk factors, particularly COPD, moderate anterolateral ischemia, and on good medical therapy. ejection fraction actually with that left main is still about 50, they say about 50+%. So this is the case compared to the other patient which Anu just did with a 20% EF. We have a third one which is on borderline. Tell them to get ready the tower. Yeah. So this case, so basically is we thought that we not use any hemodynamic support, reasonable ejection fraction, and this is a focal but very calcific disease. You can see here EF is near normal. This is that left main, very calcific chunk, left dominance, and you see that here. So this is the kind of case, if you don't do a full debulking, take this out. You don't do a full debulking, basically you will never be able to put a stent, able to expand the stent. So this is the try to do IVUS.
We
IVUS.
want to see how this patient has ischemia. The patient has a high syntax score. It looks like you went to the surgeons. It was a heart team approach. The patient refused, or they wanted to have
discussion. Discussion, and patient preferred PCI. I mean, clearly some cases you'll say it's a contraindicated, which is not the case, very rarely. And I can tell you more and more in this complex PCI, our biggest referral are surgeons. With a very complex disease, high syntax, high STS score, they don't want to touch, and they come back to us. So this particular case is more of a patient preference. This was not a decline. The first case as well as the third case we are going to show you, all were declined by the surgery. So
but
here,
Dr. Sharma, I must say I'm not very impressed with the degree of stenosis yet.
Good, very good. Show the IVUS.
You can show us something.
Yeah, and you see the IVUS there.
4.7.
And look at the IVUS, 360-degree arc of calcium. So much so that we are going to show you that IVUS catheter will not cross. Go on fluoro again.
4.8 ml.
Yeah, here is the wire, and you look at the IVUS catheter.
All left main is diseased.
It's struggling.
Okay.
So very
Is everybody
bent.
convinced this is severe stenosis on the panel?
Yeah, for the left main for sure.
MLA was
sure.
4 point change. 4.7 with the left main being 6. Look at the circular arc of a distal left main, did not cross IVUS, and it's a 4.7 by measurement.
Okay.
And patient has symptoms, patient has ischemia. So I think we all things put together. It's not a 99% left main, but clearly 70-80% left main with a lumen of 4.7 on IVUS and calcific that the catheter would not cross. So with that note, we are ready here. Because of this calcific, I thought let's get
This
some
time you're going to use a big burr, no?
Yeah, so what we did in this particular case, so after this, we used the micro 14 to cross the lesion and then exchange. This is the micro 14 after crossing the lesion with the fielder and then change it to the rotawire. So we had done the 1.25 rotabar, 1.75 rotabar already. It's an 8 French VL 3-point guide, 3.0 guide. Now see this here. Disruption of the calcium, but still there is a very tight lesion in the distal left main. We are ready with the 2.15. I'm not repeating IVUS yet because angiographically to me it's still very calcific chunk.
So
because stent not going to expand.
your burr.
We are using a
Everybody agree
2.15
here?
bar.
To do this, stepping up the burr to a second burr, I mean, would you have gone with a larger burr up front, maybe a 2.0 burr? John?
Usually we would step because 2.5 is pretty aggressive, and I think you're going to shave a lot of material if you start immediately with a 2.5. So I would rather start with a 1.75 and then upscale to 2.5 after that.
Dr. Matthews?
For this one.
I think I agree with that. I would definitely step it up, but 2.15 is a little too big for me because of the bad angle. Because left main to LAD angle is bad, and I would be more cautious because perforation.
Dr. Sharma, if I can ask that you kind of take us through this step by step, because you really performed so much rotational atherectomy. Everyone's asking us, what is his secret for not such a high CK leak? Can you just take us through this? Tell us how you are performing this.
So, I mean very quickly that tough cases, don't use the rotawire. Primarily use your regular wire with the exchange catheter and of course the appropriate sizing of the burr. And overall burr to artery ratio, keeping it about 0.5 to 0.6 maximum. This angulated vessel, you don't want to go even a 2.0. This one, because of the angulation, we had difficulty with the IVUS, we knew already, so we used a 1.75. And then choices whether you use 2 or 2.15. We are ready with the 2.15 and we'll see. that technique, the appropriate sizing, changing your rotor wire, not going with the rotor wire in these tough cases. This is what exactly we did with the Micro 14. Second, the technique point of view, and one of the important is that you have taken the tension when you bring the burr. So those are the 3 steps. The one, when you have brought the burr at the ostium, that you have taken the at the advancer knob back and forth, then tied the advancer knob at the back end, and then at the tip you move back and forth, so the burr is not going to jump. So this is the whole point. The third, we always say that if a burr has to jump, does in slow speed, we already on the Dynaglide when we are going in and tap on the Dynaglide. See, burr won't jump even millimeter. So once we are ready, the back and forth to and fro motion, slow with a guide, as you can see here. Yeah, advanced wire comes back, can be advanced a little bit. Yeah. So this is the 2.15 bar. So Matthew, this was the clear case was that I agree that this is the case. If at all you use, you probably need a 2-bar approach, and this is where we went with a 1.75 and 2.15.
Yeah, I mean, you can see how the burr dips and then comes up. I mean, this usually scares a lot of people for dissections and exits and all of that.
And perforation. Yeah.
Yeah, I have one other comment. If you do IVUS after the first burr and you see that you're cracking the arc, I think maybe you can stop and not proceed with another burr. So that's another option, just to see if you still have a 180% or 360% versus some breaks in the arc.
Yeah, I noticed, Dr. Sharma, that your mic is to the right of your collar, so whenever you look away, we can't hear you as well. So.
Okay.
And Roxana,
They can
there's one
adjust
way
that.
to
Adjust the
eliminate
mic
the
a little better.
CK rises.
So
not to measure
basically,
them.
also other thing you saw, 20-second ablation, then you wait, pull back and do a little flush in between, and we use a cocktail. And
Yeah, tell us about your cocktail, your
cocktail.
anticoagulation, all of that.
Yeah, anticoagulation is in the past used to be heparin. Now all cases are bivalvulotin, and the cocktail is in 1 liter bag. Half normal saline, you have 5 milligram nitroglycerin, 5 milligram of verapamil, and 5,000 of heparin. 555, very simple calculation. And at the same time, keeping the blood pressure. Always systolic blood pressure more than 100. Now I have very expert nurses here, Vicky and the team, that anytime you see the systolic blood pressure, show it there, goes to less than 100, they will give neosynephrine boluses. And neosynephrine boluses basically is that this patient actually having a lot of PVCs.
PVCs, and also I see some
And the
skip
pacemaker
beats maybe,
report,
or is it low heart rate? And
I have a run-through wire for
Yeah.
Is the pacemaker necessary, or
Yeah,
you
no,
can?
in some cases we do, but in this case, get the wire now. You see here, this is after the 2.15 bar, and these are the important points, that not to have a hypotension during the rotational atherectomy, keep blood pressure more than 100, or basically in triple digit. To me, this is the most important technique. Technique is not even rotablation. Technique is that when you're doing a rotablation, don't let the blood pressure to go down, because once you have a slow flow, it start the process, it just spiral down. So now I'm going to rewire our...
can you show us the fluoro, please?
Yeah, go back to fluoro, yeah.
Thanance. So
Will
you
I?
keep the rotor wire is
Yeah,
still there? Or?
Always, yeah. So the kind of a landmark, it's you keep rotor wire actually also, it will use a little bit of the atherotomy way. This is now into the LAD. So I'll leave there. The question is whether we do anything to a ramus, we'll decide. But let's dilate because rotablation alone is not enough. So we need a 4O, now flextome, to combine the atherectomy with this high calcific lesion, severe calcific lesion with the atherotomy. So we see it here. And how does let's say the expense? If not, then we may have to go to the high pressure balloon, a short one with a very high pressure, because I don't think we can go beyond 2.15 bar. We do use 2.25. All of the 600 rotablation in a 500 to 600 in a year, maybe one case we will use a 2.25 bar. And
So
that
are you
2.1
still there?
Yep.
You got to go in a little more. Yeah,
that's it.
there you
Go
go.
up.
Going up.
So, the other thing we should point out is that you've had a very favorable wire bias too as you're going in.
8 atmospheres.
So that the plaque is mostly superior, and that's basically where the rotoblader cut. So you did an excellent job of debulking with this two burst strategy.
It's 10 atmospheres. Down.
So it's a 4.0
The 6
It's-
Flextome.
Flextome.
Yep.
Yeah, cutting balloon.
Yep.
4.0. It looks
Go up.
like you needed that because
Yes.
it did dilate it nicely.
Yeah.
And it went okay. No
So far, so
trouble
good.
passing
Yes.
it.
Yep.
So
Go to
the
10, 12.
atherectomy was good.
Yeah, don't go beyond 12 atmosphere with the Flextomes. If you need to go a little higher, you need angiosculpt. We could have used angiosculpt, but we needed 4.0 angiosculpt, which is not available. Only 3.5. Let's
I
take a look.
promise you that most people would not be doing rotational atherectomy and then again cutting balloon. Anybody here do that technique?
Go up.
Or
We usually
just
do
go to a
something-
regular non-compliant balloon, see how
What
it
is the 403
dilates?
supposed to
Yeah,
be?
I
we would
usually
use
like
that.
to see.
I agree with this. I mean, the combination of a cutting balloon or angiosculpt definitely gives a much, much better result, and stent expansion is
We
far
use a lot of
superior.
chocolate balloons after.
Chocolate balloon, Carlo, Demario?
You go to higher pressure.
What are you doing? How are you, you're quiet back there.
Well, because I'm seeing great results. I think it's a very good strategy. He did the ultrasound. He probably didn't measure the minimal area because, as you've seen, the ultrasound cutter didn't cross, but was obvious that there was a 360 degrees of calcium. Was a large vessel. I think the two-burr strategy was more than appropriate. And it's a great result. I think you can probably avoid the second stent. You see, you have this ectatic post-stenotic dilatation in the direction of the intermediate and circ. So I'm sure that the stent across will
So
create
this looks to me
give
like
a very
a
good
single
result.
stent, right?
Yes.
Single stent.
And it has expanded very nicely. You see it also.
So,
Yeah,
Samin, is your expertise enough or you need an app?
Yeah,
Well,
one thing you want to be careful about the wire because it looks like in a
Yeah,
very
it looks
small
like
branch. You
there's
don't
a
want to have a
bias,
wire
yeah.
perforation out of all this stuff. So
We are going to take the rotawire out after your delivery of the stent.
No, he means your distal LAD
Yeah.
wire in
Yeah.
some
is in
small,
a very
tiny
small
little
branch. You probably want
there.
to pull it out.
Yeah, I mean, I think it's very appropriate, Sharma mentioned that taking the rotawire out, because casually, if you forget, you are in for great trouble because the step up of the rotawire beyond the, at the radiopaque marker can get your wire caught under the stent.
But did you watch that? He just put the stent in, and despite two burrs, cutting balloon, it was still a little bit of a struggle to get that in, right?
Yeah.
Dr.
Well, I
Sharma?
mean, we expected this. This is
Yeah, it's a
I can tell you,
huge mountain of calcium.
This angulated left main, and it's a very complex the point of view. This is not a simple the rotation atherectomy. That's why double burr. Yeah, good. Go on.
So that means you have decided not to do anything with ramus?
Yeah, well, actually, right now looking better and better. I think more flow
Because
of
if
the
you have to
LAD.
deal the ramus, it should have been dealt now.
Yeah,
And you do not plan to stand up to the osteum?
give us a 5
But
4,
we
8 millimeter high
didn't see
pressure
the
balloon.
IVs
Go up
before,
again.
but for me,
Yeah, this is a
your left main seems
4018
better.
Zions. We are deploying at 16 atmosphere negative, and then we are going to dilate within that area with a 8 or 12 millimeter 5.0 non-compliant balloon. What balloon we have? Yeah, quantum apex.
You want to take out that rotawire, or you have taken it out?
He took it out already.
No, it's out.
Yep.
He took it out before stenting
Okay.
always, and it looks
It's looking very, very good.
What about imaging though here? And
Yeah.
I see a little bit of like distal to the stent.
Yep.
There's a
we
little
have it.
small
No, no, we
lesion,
have the
but-
imaging. After dilatation now, actually, our surgical point of view, they are ready apparently for the TAVR.
Okay.
So if we can go to a room
We'll
6.
go to the TAVR,
and
but
we'll
we still
complete
want
it.
to
If
see
need to be,
if
we'll
you
show it
pass
in
the
the end.
IVUS
Yes.
catheter there.
Yep.
Okay,
Okay.
TAVR, here we
can go to
come.
room 6 now.
Room 6.
All right.
Thank you. Case number 3, thank you.
Okay.
Excellent. Okay,
Well, do you see us though?
I see case number 3. I see Jason Kovacek. Hello, Jason, and I hear George Dangus.
I'm right here on the left, but I'm a little taller. You don't see me much. There you go.
Okay,
In
good.
between Jason and I, we're throwing off the height.
And Dr. Kinney
the
right
height
there.
resolutions there. That's why I have Dr. Kinney with us.
Okay, so we have case number 3, who is a TAVR AI. So if you just see, we are in a TAVR room, which you will see interventionalist. You have our surgeon, who is Alan Stewart, and we have a vascular surgeon, Dr. Rami Tadros.
Rami Tadros right here, coming next to me, Dr. Tadros. Yeah, he is.
All
It is
right.
Expert cutback.
Okay, quickly we are presenting the case GD.
75-year-old patient with dialysis.
We can't hear you.
75-year-old patient with dialysis post-bypass.
Okay.
Pacemaker, severe COPD, and various other comorbidities, including diabetes and CHF, is an inoperable case of severe AS, as well as with some moderate degree of mitral annular calcification. The baseline EKG is a 30-degree heart block, and other than that, the bypass is closed. The LAD has moderate degree, about 50-60%. We do believe the bypass was in the time with an unsuccessful angioplasty with a dissection, so it was patent for some time. Patient did very well, but subsequently bypass closed because obviously the dissection must have healed. So this is the overall scenario. The patient deemed inoperable due to all this comorbidity, STS score north of 10.
So a patient with class 3 symptoms, severe AS, post-bypass, CKD on hemodialysis, already on a permanent pacemaker, obviously high risk, not an intermediate risk, high risk. So a lot of calcification. What's your strategy? How are you performing this? Go forward.
Yeah. Well, next slide, please, and we can review the echo. You can see the high velocities.
Okay,
over 4.
Dr. Chowdhury, can you just, he's our echocardiographer.
No.
They
Go back one slide, please, to the echo, and Dr. Chowdhury can give us a summary of today's TE.
Okay, Dr. Chowdhury. We can't hear you, Dr. Chowdhury. The mics need to be all fixed in that lab. We can't hear him at all.
No mic.
George, is the patient on constant sedation?
No, the patient...
No, one second. Let's proceed then. We're going to get Dr. Chowdhury in a little bit, but let's say that
patient had to have a GA.
Significant aortic stenosis here. Show the next slide. You can see the CTA that indicates impossibility for this is the valve CTA that you can see the annulus. Jason, you want to give this review?
Sure, good morning everyone. So the main feature of this annulus is that large blob of calcium, about 430, that you can see there. So the perimeter is about 67.9, area is about 3.6, but the diameter across the valve is about 19 in the short axis, 23 in the longer axis, but across that blob of calcium is only around 16, 17 millimeters. So quite a challenging anatomy. The risk in this case, we think we have to balance here, is the risk of annular rupture if we're too aggressive with post-dilation versus how much paravalvular leak we're going to accept in this case that may be leaking around that calcific nodule. Next slide. Just to take you through the CT now. Next slide. Good, so here you can see the LVOT. Dimensions are about, diameter is about 19 millimeters. The calcific nodule does extend down into the LVOT, which is another feature that we have to be mindful of for risk of annular rupture. Next slide. Next. Here you can see the SOV, mean diameter is 29, which is adequate for the size valve that we'll be coming to. Sinotubular junction height is 22, ascending aorta 27, all very reasonable, but of note you can see the calcium extends up into the leaflets in that upper panel there. So quite a lot of calcium associated with this valve. Next slide. Here you can see our access plan, and this is quite complicated. The patient already has a pacemaker. The patient has a dialysis fistula in the left arm. So really left subclavian access was problematic in this patient because to do a left subclavian access, and we'll come to the iliacs in a moment, left subclavian would require us to take the pacemaker out of its pocket to get to the subclavian vessel underneath the pacemaker pocket. And if we had complications, we'd also mess up the dialysis fistula. Right subclavian was unsuitable due to severe disease. Next slide. So here's the transfemoral access approach. You can see a lot of calcific disease, and at the common femoral access point, again, a lot of calcific disease. Next. You can see here some of the dimensions. Just to summarize this, bilaterally the minimum diameter is 3 to 4 millimeters, not quite circumferential calcium, but severe calcific disease the whole way up. We normally need around 6 to 7 millimeters for easy access. This is well below that, but because of the problems with the subclavian access, this was actually our preferred route of approach. in conjunction with our vascular surgeon, Dr. Rami Tadros, who does a lot of these kind of access cases for doing TAVR and EVAR with very large sheaths. So he has a deep experience in getting in and out of these kind of vessels safely with large sheaths. Next slide. So just to summarise the valve choice, it's a 26mm Evolut. We're going to go with the Evolut Pro, and Dr. Kinney and Dr. Dangus will talk about that. But by all sizing measurements, this is perfect for a 26 Evolut valve. Next.
So the summary of the case is a critical AS with a high syntax, with a high STS score, inoperable for comorbidity reasons as well. And we had a right femoral cut-down access with Dr. Tadros. We're going to proceed with a BAV with the 18mm according to the lower diameter of the valve. And while we went up with a BAV, you can see we have the confida wide in the ventricle. We have a 20 French sheath. I'll let Dr. Tadros speak a little bit about the access while we went in with a BAV.
Before that, we have to tell them the important question. I think one question from Ron Waxman is, what's the anesthesia? Right now, patient is under GA because of the cut down that we had. Otherwise, we have at least 60% of ours are under conscious sedation, the TAVR that we do. When they are cut down, or the subclavian that we do, then they're going to have a GA. And once they have GA, of course, we will have a TEE. Otherwise, majority of the cases, I would say 30% of the cases, echo will be done transthoracic. Otherwise, they will have a pediatric probe and do a echo at the time.
So I think one of the most important areas here, and I want to just, as you guys are pulling in and out, is the fact of this nodular calcification on the valve that I think we're all concerned about, worrying about a rupture, but balancing that without having a paravalvular leak.
You can check TE after valvuloplasty now.
Giuseppe is here, Rhodes, Kabul. Giuseppe, how would you approach, would you choose Evolut R here, or would you go with Sapien? How would you choose this? Tell us what you think about this.
I would, my choice would have been also an Evolut R without predilation. I think that the amount of oversizing would be enough to seal the annulus,
so you would
and
not do
having
balloon.
a good result, direct TAVR, yeah. In these cases, we try to avoid any balloon dilation.
I agree, because I think that you can get again the same rupture from the balloon.
Okay.
What were you afraid to do with the
What was the TE after the balloon? Can you do a TE, please?
That was a very interesting point
Yeah,
that
even
they
if
have
the balloon
raised.
was not a big one,
So did you guys hear that? So the panelists are questioning your pre-dilatation and valvuloplasty.
Roxanne, I want to intervene. Recommend pre-dilatation because I think that the danger of annular tearing or rupture is most when if you have to post-dilate the self-expanding valve. So the danger of annular rupture during post-dilatation or self-expanding valve is higher than during pre-dilatation.
Right, so you feel that this, so it's interesting. It's a nice, interesting comments here. Talk to us how you're positioning your valve,
so now what you have is same. You will have the pigtail in the non-coronary cusp. You see that? That's what George is adjusting. And this is where we have, T can come up a little bit, please. T come up. If you see that, this is the implantation view. So if you see the implantation view, you will see on the right side of the screen where you have to see your 3 sinuses, and that is when you see the lower part of the 3 sinuses, you will draw a line that is called as the.
Let's play this view, Jason. Play this view, Jason. Off floor a little bit. Play this view.
Their question was, why do we do
right here? We have this pre-implantation view that you can see here.
You see that?
You can see nicely the 3 cusps.
And the bottom of the 3 cusps where you draw the line is the annular plane, and that is where we are focusing to have our valve just about 4 millimeters. Just
post-valvuloplastic was severe AI or no?
No.
So you moved, you moved the pigtail now to the non-coronary because before it was
right now we moved it to non-coronary.
T up, please. We don't need T at this time.
I think
Looks
we're good.
And
let's start the deployment.
The T is just a disruptor.
So the steps of deployment here very simple. He's going to start rotating after.
Pace 100, please.
Slow and go very slow.
Okay, we have stop. Cine. Inject. Nice. Now the next rotation, you start flaring. When you start flaring, I'm going to give the instruction of pacing at 150.
Alert test, please.
Pace 150. This is the time. You want to decrease
So you
the cardiac
flare
output.
and you start
Good.
pacing, and now
And that's the
you're...
time you start releasing.
Jumped in
Stop.
deep. Very
stop.
deep. It's
Inject.
very deep.
I think we're okay.
It's pretty
Yes
deep.
and no. Let's see a little bit.
The patient already has a pacemaker.
Yeah, just do it slow so it's not
Now,
going to sink in
very
further
important
in.
at this time you have to make sure there is no parallax, which means your, the diamond of the posterior part and the anterior parts are lined up. Why is it very important? That it gives you the accurate information, the view of the depth of the implant. So if you check your parallax, we're looking good.
Yeah, I think that
Another view.
there's minimal parallax
Yeah,
here.
minimum. Very nice.
Deep or we are okay?
I think we are good. We are ready for release.
Well, let's
unless the
check it.
pan
Let's
is-
check it with Dr. Chowdhury also. Let's check the TE a little
Yeah,
bit.
let's hear
We
about
have a
the
little
echo.
question there.
What are you
Chowdhury,
looking?
check a little bit on the TE point of view, the depth.
What are you looking on the echo right now at this point? Because the valve is not completely deployed, so you're going to have PVL at this.
No, we're only looking at the long view now to see if we're too deep.
Angiographically looks good.
I don't think so over there.
Okay, we are ready to deploy. Pigtail is out.
Just do it
Echo up.
slowly,
Echo up.
very
Echo up.
slowly.
Can you show us the fluoro, please?
Echo up.
Full screen fluoro.
Echo up.
Right, thank you.
Now you have to be very careful. We just want to make sure all the is completely released. Okay, wire.
So you
let's-
already pulled the pigtail out.
Come back.
before you
The
deploy.
pigtail is up, and we're doing a little maneuver by pushing the equipment all the way in before we take it out to align with the push the wire in, please. Push the wire in.
And take the wire out.
Very good. Okay, TE can check now again.
So the key point for the TE, of course, is that the calcium is extending from the
Jason, you
mitral
have
That's right.
annulus and leaflet, and
Wanna
that's
take it
where
out?
the
We might as well
LV
take it
outflow
out.
tract
Just fluoro a little bit.
component is.
You guys are, we're a little bit getting out of time, so you're going to need to show
No,
us.
we are actually done here.
Well,
If
we're
it looks
sort of
good-
done here. What do
Yeah,
you mean out of time? Let's see what the TE results show.
Well, you were supposed to do 4 cases, and we only got done through 3.
I
So you
understand,
better do
but-
better.
We are done.
Everything will
Because I would like to proceed to our,
Go next case.
Well,
Ready?
You're
Not
tough.
yet.
Topics.
No,
They
not
did
yet,
it
not
in
yet,
10
not yet,
minutes.
Not yet.
not yet, but
Not
let's,
yet.
I know,
We're
but,
ready for the 4th case. Yeah, lot of paravalvular here.
okay, show us your results, please. of your valve.
Guys, unless we deploy the valve, we don't have a complete case. So, we cannot rush and complete the case before the valve is released. Just was done. So please, TE can show the post leak, and we're going to put a pigtail in the LV.
And the hemodynamics,
Dr.
George.
Dilate here, big leak.
Post.
Post dilate first.
You need to post-dilate here, it
Post
looks.
here.
Yeah, I'm not sure. Yeah,
20.
I
probably.
can't see.
Probably you need to.
He's
yeah.
saying minimal.
Can we hear Dr. Chowdhury and the echo, please?
You can see that the frame is not very well expanded at the area of
Exactly.
the
You can leave
LVOT.
Diastolic pressure.
Yeah,
is
but
good,
sometimes
echo,
with
nothing.
some minutes, the
Okay,
valve
let's go
continue
with
to
the 20
expand,
Zimet balloon dilation. I mean, 20.
So, Dr. Usia, they still have to post-dilate here, even with the pre-dilatation.
I will wait
so-
a few minutes, and also
Yeah,
I
sometimes you
will
can wait.
check the hemodynamics.
I'm not so sure. Let's Dr. Chowdhury again. Let's show us a paravalvular.
I see it. We can't hear Dr. Chowdhury at all.
He's saying there's a
Minimal
paravalvular
paravalvular.
leak.
Minimal paravalvular.
So if you see the hemodynamics, why are you showing the echo in 2 screens? Can you show hemodynamics or no?
Okay, let's put the pigtail in.
Maybe we ask the panel, see what they think.
What is the
What is
diastolic pressure? What is the end diastolic pressure? These are also
Diastolic pressure
parameters.
is
Oh, we don't have a diastolic pressure because we
diastolic we
haven't
don't
crossed
have.
again.
He's going to cross right now.
You do
back
have it
in.
now. No, you do have diastolic pressure now.
Yeah,
Joseph,
let's-
So that's
would
a
you
good diastolic
post-dilate?
pressure. It cannot be a lot of PVL.
Want us to cross.
I'm not sure here. I
sure
I
yet.
would pull
Let's
back
cross
the
with the
wire,
pigtail.
Yeah,
and I will do hemodynamic measurements and then an angio.
exactly.
What,
Another echo evaluation,
what's
but
the
I think the
recommendation
result
from
is good.
Dr. Usia? I did not hear that earlier.
Dr. Usia?
I would put a pigtail, measure the hemodynamics, and then I don't think it is needed valvuloplasty. I think is good. Maybe if you can.
You see the jet? There is a jet there.
Yeah, but
Well, there is a jet, but a small.
can we have also another projection? Maybe a right anterior oblique with the caudal.
Okay, let's see the hemodynamics.
For me, it's the hemodynamics at this point going to make the final decision. Because there is always a risk again on those patients.
Yes, of course.
Forget about this. I have this other procedure.
Yes, and with the S3, you have your immediate
this other
result.
question.
But with a self-expanding valve, it continues to expand.
Yeah.
It's not working.
It's not working because I haven't opened it.
Can you show us the hemodynamics on the full screen?
Okay, there.
Yeah, we see the hemodynamics.
Here we go.
It's perfect. It's good.
And diastolic pressure is 16.
I think you're done. You have good
That looks
hemodynamics.
really good, huh?
And yeah, you probably
think we're
should be
good.
okay. Yeah.
That looks good. Is that enough for everybody, just the hemodynamics, even though you're seeing
It's not
little
enough,
jets?
but it's in addition to
enough,
what
right?
you're seeing on
Yeah,
the...
I want to hear from everybody.
Echo, angio, hemodynamics.
Echo plus hemodynamics. Carlo?
If you have no issues with creatinine, why don't you inject without, of course, the wire and just confirm that is a minor leak?
Ready?
I mean, we didn't see full screen the TOE,
Okay, T
so
up.
T up.
All right.
5-10% of the
minimal,
circumference.
minimal AI by the final
By every measure.
every measure, and given the fact that we have the Pro, the Corva Pro here with an external wrap it allows advanced sealing of the last 1.5 cell at the bottom of the valve, about 14 millimeters. So this will allow, I think, over time, hopefully,
It will keep expanding.
Get rid of it.
It'll keep expanding, and then hopefully in the 48-hour echo will look good.
Yeah, you're
Okay,
done.
Dr.
It's
Kinney,
very nice.
Yes.
if you don't mind, we're about 10 minutes
Yeah,
behind.
you move on.
We would like
You
to
move on
move
to.
to our lectures because I really want to keep
No,
things everyone has.
Please, go to room 1.
Yeah.
Dr. Sharma is waiting for you guys there.
Oh, yes, Dr. Moreno over there.
Let's go to room 1. He's got Dr.
That's the trick.
Sharma, 1 minute.
Yeah, no, but listen to this. Let me just say that.
I'm tough.
Okay, no, but I really like it.
He
When
can
say that
finish
now
in
we have
1
to take a
minute.
break. So they have to end up that hemodynamics. To me, should be a little post-dilated, but that's a minor. But overall, we also learned that mild to moderate leak, paravalvular leak doesn't matter. It's a moderate plus is the one trouble. But anyway, with that note, this is the case. And I know, Roxana, we are 5 minutes already late. But we'll be total 15 minutes late for this session, and that 15 minutes, you push everything further, we'll catch up in the afternoon. With that note, and we have a beautiful
Your
case
screen
number
will
4.
go black. You better go fast.
Let me
Yes.
show you. We leave the best for the last, Roxy.
For the first session.
Yeah, look at this case. She's 79, and she's end-stage renal with diabetes, and
not
she has a non-STEMI. Do you hear me?
Okay. Yeah, we hear you. Keep
Okay,
going.
so she has ST depressions across the precordium, and the troponin was 15. This is the cath. You see the
Now
lesion.
show the cath. Go back to the
Show us the
angiogram.
cath.
Patient had a surgical discussion with that
this
disease.
is the RCA, distal RCA is there, and this is what we see. So calcific ostial bifurcation.
Left main.
Bifurcation
Left
morning.
main, yeah.
Our left main theme. Go to scene minus. So this
Okay.
is the case.
Wow.
So we're gonna start. We already wired for the rota, and we have go to the.
Yeah.
So this is the one looks even tougher than your first and second one.
The worst
what I
of
said,
the morning, yeah.
I'm glad we only have 5 minutes to do this case.
No, we have 7 minutes. Don't make us anyway.
going,
the
Dr.
more
Sharma.
important is
Most
listen.
important.
To the high max.
I want to be documented that I am wearing the cap and mask.
Yes.
Go to the
And you
column.
can identify me by my name apparently is written somewhere in the cap.
Okay.
Which I used it first time. So I'm totally identifiable despite my cap and mask appearance. But anyway, we are ready for this bifurcation. Pedro has wired it already in the 1.75 bar. We are ready because of that calcium. Good. Off Dynaglide now. Yeah, go.
So you're
So we
inside.
start at 158.
Yep.
Guys, you're okay.
Let's go.
What's
Here
the
is the
blood in the vein?
175 burr. We have an 8 French in case we need to use the 2.15.
And no protection on this case, right?
This is an ascending part of the left main, and we have a floppy wire.
Yeah.
20
So
seconds.
clearly that we could not have used a bigger bar. Has to be 1.5 or 1.75. We have 8 French guide. We need to go to a 2 or 2.15. We can go, but this is clearly the first one. very angulated again. Go, keep
She
going.
also have 15 millimeter gradient across the aortic valve and 10 millimeter gradient across the mitral valve. So we have to put a balloon pump.
So this is the case because of the non-STEMI. Recently, EF about 45%. We are putting a balloon pump. We have used a balloon pump in this particular case.
So here you have to be careful.
Yeah.
Because of the 20.
Pull back. Again, 20 seconds.
We can increase the speed. 170.
So,
Ready?
as you guys are doing this burring, which I think is going to take a while, why balloon
Go
pump,
higher.
not Impella here?
Okay.
Dr.
I'm gonna-
Sharma, why balloon pump, not Impella? Did you hear me, Dr. Sharma?
Yes.
Why balloon pump, not Impella?
Yeah,
What about
because patient has
Impella?
aortic stenosis.
Yes.
That area is about-
Severe aortic stenosis, moderate.
It's mild.
The patient has a gradient of about 20, valve area about 1.3. In those cases, although we have done few cases, we even balloon valvuloplasty for severe AS, put a Impella, and then do unprotected left main PCI. But clearly, this is giving us trouble, even 1.75 bar.
You may have to downsize.
Yeah.
Yeah, this is a very angulated segment,
Yeah.
and they're using
And
meticulous
we
approach to
increase the
doing this.
speed already.
Yeah, you want to use your one.
You really don't want to go
It's
through this
pecking.
slow. You want to go through quick. You want to speed up
Yeah, we're going to be
quickly.
stalled. If we just push it, it will go and then we won't come back. So
Yeah.
we're going to undersize.
Yeah, let's see once again how much we have crossed. Yeah.
Not
You
much.
still have a lot of work to do here.
Do another one.
But I think a
So
1.5
Let's
would
try
more.
one more and get a 1.5 bar.
Like a calcium nodule there again. Yeah.
And we already increased the speed to 170.
You know, one
Usually
thing,
we
but-
do 150,000 RPM. We already made it to 170.
Yeah, here I missed the extra
It doesn't
support
have the-
wire.
pushability.
You have-
And if you push too hard, you
That's
can
okay.
stall.
Yeah.
We'll come
So
out.
it looks like you're
Come.
going to downsize
Go.
this spur now.
Yeah. Yeah.
So what's
1.5.
your technique? So the technique is go down now to 1.5,
First thing, first
then
thing first.
upsize.
Yeah, first thing first, you increase the speed from 150 to 170. If that doesn't go after 2-3 times, then you go downsize the bar. In this
Okay.
particular case, because of that angulation, I think 1.5, even to start with, would have been an okay choice.
Okay. And then you plan to do a higher burr, I think, after even the 1.5 because there's so much calcium there.
Yeah,
right?
no, but definitely now we know whether we go with a 1.75 after that or we go with a 2.0 bar and need to be seen.
Okay.
Yeah, but let's see how the 1.5 behaves. We may even have a trouble with 1.5. We don't even know.
Okay.
But I think the 1.5 we should be able to get through.
Should be going through, yeah. I
In
think
these
so.
cases, you wouldn't consider to do CSI because of heavy calcification. Is that
Yeah.
correct?
And
The
also
two cases
that
you showed today.
angulation, you see that angulation, I think. When do you choose CSI, the orbital atherectomy?
No, I think the patient with a severely calcified but not that angulated and not a very large vessel will be the appropriate case for for the CSI. We'll have a CSI case later.
Yeah.
But here, because our goal was, I say that anytime you're thinking 2.0 bar, then you don't use the CSI because CSI will give you the orbital bar maximum 1.6 or 1.7 lumen. So once you're thinking about 2.0, the CSI is not the right choice, then you had to go with the atherectomy. So two regions, in this case using rotablation rather than orbital, is that our ultimate goal was more debulking using a 2.0 bar. And secondly, the angulated, very angulated vessel, we have seen little trouble with the orbital atherectomy in these cases.
Okay.
Ready?
What the hell?
Okay. We're going to test the speed now.
What is going on? Your surgery?
Ready?
Huh? Mitral clip you're thinking is mitral clip?
Okay.
Good. Okay. We are going with a 1.5. Now I also know, put the hands to the side please. Yeah, keep going. Good. So what we are going to do, Roxana,
Yes.
that once we go with this bar, what you can do is we can play this on one side and you will continue the case and you'll start your lecture series.
Yeah, I think we need
Yeah.
to start this lecture
No,
series. I
clearly
think
at
this one.
10:15 was our limit.
Go to the
Okay.
high mag.
Yeah. Good. Yeah.
Okay. Dinah.
Yep. Same.
Okay.
Go. Okay, we are starting now.
So now we have the 1-5 burr,
Yeah.
still with this slow pecking as you watch. You can show us also hemodynamics if you like
Yeah.
on the right or somewhere in the small box.
Yeah. And it's a 170 already. Okay, pull
Yeah.
back. And the blood pressure actually is nicely maintained. Hemodynamic augmented pressure is 180. So we are doing
Okay.
good from the hemodynamic point of view. In this case,
Excellent.
keep going.
Okay. Wow, even the 1-5 burr is not really, it's
Yeah.
really taking
They're doing the
a lot of
turn.
calcium.
Maybe we should try the extra support wire.
Yeah, then as you may ask earlier, what else can you do? Then in the end, you can use the extra support wire. That may give a little more wire bias, but that's the ultimate would be.
So did you consider to do a guideliner to give you a little bit more proximity?
Well, I mean, I think this is just basically is the
think
bud
it's
issue.
the
You are right.
calcium.
If you cannot cross and then not deliver, maybe. But let's give a little more time.
Because it's the issue of pushability as well because of the
No, you see
angulation.
that we have the long sheath. We have a 8 French guide which is nicely settled there.
But since it's only 1.5, why do you increase the revolution per minute to
He already did.
200,000?
He's already. Oh, would you go up to 200 speed? The question Carlo DeMario is
Okay,
asking.
let me come one second. Let me try. Yeah, we are going to go a little more now. Let's go to 180. Right now we are 165, 170. We are going to go to 180. And same, what you need to do in these cases, as Ran just pointed out, you need extra support. So hold the guide. If you can show my hand, hold the guide with the left hand, and while you are doing the burring. So clearly, so you are basically just holding it, not pushing it, holding. And go to 180. More. Little more. Okay. Yeah. So then same, packing, touch and come back. No, this is okay. It'll be all right.
You're making
Yeah,
progress.
it did. It did.
Do you
I
have
think it
a
just heard
drop in
something
the
there.
RPM as you do that, or you don't have a
See,
drop?
the guide,
Now
you
you
have to
cross.
hold the guide. That's the key. Yeah, that's okay. Once you're done, otherwise 20 seconds, but once you're polishing, you could be a little extra.
Yeah,
Okay,
so-
we are
so
coming
the
out,
support
we'll
really
take the
helped.
picture and then we'll decide
Very nice
what to do.
demonstration.
That was a very nice technique you
So you
showed
have a-
us.
But
You have an
just hold the
extra-
guide.
Support.
And you saw it that no pushing of the guide. Guide never push, but you have to have in these tough cases because burr is going to will not go advance and will come back. So very important that you hold the guide while you are doing the work. Okay, ready for injection, guys?
So this is really an excellent demonstration of the algorithm for how
Very
to get
good
through a tough lesion with a rotoblader.
That's right.
Going up with increased
Wow, look
speed.
at that.
So now with this clearly
Downsizing the burr
is that,
and back up
So
and
what I'll
support.
do is, for the sake of time, it's the 10, 15, 16 actually. And Roxana, you can start and
Yeah,
we will be
we're
on.
seeing a little bit
mute.
of plaque shift into
Yeah,
the circ.
which we expected.
So we want to know what's going to happen. Is this now turning into a 2-stent?
Yeah.
As
No,
we're watching
No,
this?
we were thinking about 2-stent to begin with,
Yeah,
but
you need-
I will
you
not
need
do any more
stents.
rota now. I'm going to
Okay.
wire LAD and circumflex, and then we'll do a same mini crush technique. And you can put us guys on the one side of the
Put
screen,
them in the
and you
small
start the
box
lecture.
on the side. We're going to
Yes.
but with your permission, we're going to move into our
Absolutely.
hot topics.
Yes.
Thank you very much. Beautiful 4 cases. Thank you.